Thank you very much. It would have been 4 months on, but obviously due to circumstances, this has now moved. So we're now pretty much 6 months on, actually. And, you know, that's not a bad thing. And actually, we're now past the compliance date for those organisations in the community and in secondary dental. So a lot of you in this room have probably seen this presentation in one guise or another, because NHS England, we like to recycle our slides. It's easier to get them through comms that way and tend to use them for a year out on the circuit. However, I like to try and talk to some of these and some of the changes, because things change all the time in our world and there's some great things that are going on. But I think it's really important to understand what's going on at the moment. So, okay, we always talk about cleaning as a science and the power of partnership, and that is really important. You've heard Phil talk about that. Other people have talked about that. It's about leadership. What do we mean when we say power of partnership? We mean working with your clinical colleagues. We mean working with your FM providers, with the building providers, with other support teams, with your hard FM colleagues. It is so important. Everything we do has to be done through multidisciplinary teams. So we've got a big challenge. We know this. It hasn't changed essentially. Obviously, we've had COVID in the middle, but we've always got something going on in the market. We've got a fragile market. We know it's difficult. A lot of you sit there and go, new standards, great, but how do we implement this without spending loads of money? Workforce. We know there's always issues trying to get new workforce in, training them up, people with experience innovating with that workforce as well. We've got the UK's exit from the EU, still in the background, you know, gift that keeps on giving. We've got a variability in cost and quality of services. It changes from trust to trust. The idea of these standards is very much about us trying to work together to get a good baseline across all services, and that's all healthcare environments. We've got trust resource constraints. We know this, you know, for our FM partners in the room, they know, they'll go, look, we need to do this, and the trust board will say, but we've got no money, so how do we do this? So that's about partnership working again, finding a way to do that. And those with in-house services, again, there's a budget, and there's always somebody looking to go, can we shave a bit off that budget? We've got the driving digital agenda. It's a big thing, and it's great, but it's another thing we've got to try and work alongside. And there's the changing NHS landscape, and it's always changing. For those of us that have been in the NHS long enough, we know if we sit around long enough, everything comes back round again, but it's still an ever-changing landscape. So this is a bit about what we do every single day. And, you know, I've been putting some of these numbers out for a long time. However, they change all the time. This is what we do in Soft FM. We're serving 227 meals every minute of every day. This is England, by the way. So when you go beyond England, it gets even bigger. More people are sleeping in our beds every single night than there are hotel rooms in London. We're cleaning an area the size of Gibraltar 3.5 times every single week. We're using enough energy to power up 200,000 homes. Our restaurants cover an area of over 218,000 square metres, which is larger than Warner Brothers in Abu Dhabi. And we've got 39,916 whole-time equivalent cleaning staff, which is equivalent to the number of runners in the London Marathon. So it's not a small service, and it is, you know, it's all of us in this together. So let's talk a bit about the journey, because it's great to talk about where we're going and how things have gone over the last few months since it became compliant for people to meet the cleaning standards. But I like to talk a bit about the journey as well. And there's a lot of people in the room today who've been on this journey. I started, as Michael said, I started work in 2017 with NHS England or NHS Improvement as it was then. And my first job coming out of a trust was, got to refresh the cleaning standards, really important, hasn't been done for a long time. So we convened a large working party, FM partners, people from trusts, suppliers, all sorts of things. And we sat in the room and we go, well, we're refreshing it, we're reviewing it. We can knock this out in 8-9 months, that'll be fine. And everyone in the room agreed we could do that, it would be great. So by 2018, a year on, we started running some pilots to decide, because what we tried to do was take the best of PAS and the best of the 2007, because we didn't need to throw everything out. You know, there was some really great stuff in both of those, but how do we combine it and how do we make a standard that has enough flexibility for people? So we ran pilots and they were great. 30 trusts, including a couple of hospices and GP surgeries took part across England and Wales. It turned out they actually hated the standards that we'd put together. We'd used very much a PAS approach of red, amber, green, and it turned out that clinical colleagues couldn't understand in a hospital or healthcare setting why anything wouldn't be red, and therefore we were going to basically clean everything 4 times as much as we needed to and audit everything on a weekly basis. So the group got back together and said, this just isn't going to work. So we took all of that and we amended the documents. We got really great comments and feedback, and it was brilliant. That allowed us to reflect our own thinking back into the real world and make the right changes to the document. So in May 2021, slightly longer than that, 9 months, you'll remember we thought it would take us to launch them, but in May 2021, we managed to launch the new national standards for healthcare cleanliness. We ran national webinars throughout June. We did some localised calls and presentations. We've got central support ongoing. One thing we never do in NHS England, certainly me and my team, whatever we are delivering, we do not do a mic drop NHSE out by you're on your own. We are always here to continually update the standards, and that includes the working parties that work on that. We've got great support from people ongoing that are helping trusts to find their way through issues. So the first compliance was due in May of this year, as we say. We're now 6 months on from that. And the final compliance date for the community and secondary dental areas was November 4th, so not that long ago. That would have been last week, wouldn't it? And essentially, we have had the initial compliance date, we had something in the region of 12 trusts come to us for temporary derogations. I'm going to look at my colleague now. Most of those are all done and dusted now. I think we've got 2 that are just still ongoing. And we haven't received any derogation requests from community or secondary dental. So, you know, initially on the surface, that means great, everybody's doing what they should be doing. I certainly hope so. So let's talk a bit about the document itself. The ethos of the document was really important to us because this is what we're trying to do all the time. So we've got collaboration. We've talked about that power of partnership, and it is so important. It's working alongside everybody. Cleaning is everybody's business, and we have to make sure that people understand that. Transparency and assurance. You know, we've known for many, many years we've meant to display the percentage of cleanliness that we achieve in areas, which is great if you're technical. If you're healthcare cleaning professionals like we are, that's great because we all understand that score. We know in a low-risk area we've had to achieve 75%. But if you're a patient sat in that area, even in an 85% area, significant risk area, you could be sitting there going, well, am I sat in 15% that isn't getting cleaned? We know that's not what we're saying. So star ratings was a natural progression. It's simple. We've still got those percentages behind that gives us our information and allows us to work through what we need to do. But it's a very simple thing for patients and other staff around the hospital to understand this area has achieved a 5-star rating based on its risk. But what else sits behind that? Efficacy auditing. You know, previously, and my lovely colleague Colette in the room here, who I stole this off her many years ago, she knows this, but we've done visual cleaning for a very long time, which is great. But if we take a glass and spit in it and clean it, it's a visual audit. So I'm going to put that back there. You're all going to come along and go, yep, that's clean, and you're going to give it 100%. You're going to tick it's clean. But it's not. So what we've got with the efficacy audit is it's about looking at how do we do things. Do we train our staff and develop our staff? Have we got the right cleaning processes in place? Have we got the right equipment? Because it's no good if we're telling, you know, our cleaners, here's 4 cloths, disposable cloths, you've got to make them last all week, and they're there with a pair of scissors trying to cut them up. Have they got the right chemicals? Are they mixing them correctly? there's a lot of things that help to show that the efficacy of the processes that we're doing. Infection prevention and control, we know how important, and this became a huge thing in COVID. Somebody suddenly realised how important our domestic staff are in helping to prevent infection prevention and control. We've always known it, of course, because we've just known it's an important thing. But the standards makes that much clearer. And of course, continuous improvement. Now, it's an interesting thing, this, because if we reach 100%, how do we improve? There's always something we can do better. It's not just about, you know, is this area 100% clean? Because we know the reality is it's rare for anything to be 100% clean. There are always ways we can improve and things that we can change. And we are working in busy buildings, essentially. So there is no way we're going to get 100%. And we need to accept that, because the only day, even on day one, your hospital's brand new, no one's walked in the door yet. If you've ever seen a builder's clean, you'll understand what I mean by that. It is still not 100% clean. So some of the highlights, and I know, you know, everyone in this room will have their cleanliness charters up. This was designed around something, again, it's the transparency aspect, but something that people can see everywhere they go. So there is something about what we will do as an organisation, but there's also something about what we want patients and visitors to do. We're healthcare organisations. We understand that accidents happen, but tell us. Don't allow someone else to walk into it, and then we can deal with it. We're never going to get the funding to have a valet outside every single toilet in the hospital or across healthcare, so we have to be sensible about those things. There's something there around the cleaning tasks. Since 2007, we've been asked to display work schedules. But does that really work? Because we know when the domestic walks on the ward at 7 a.m, the schedule says, go clean the toilets. But the nurse in charge says, hang on, we've had 4 discharges, I want you there. So straight away, they failed because the schedule says they should be there at that time doing that. But we don't need to know what time they're going to do this stuff. What we need to know is how often are they going to do it. So that toilet cubicle is going to be cleaned once a day, twice a day, 4 times a day, 20 times a day. That's what's needed and whose responsibility it is. So this clearly gives everybody the information they need without setting people up to fail. Star rating, we've talked a bit about this. Again, there's a lot of work going on in the background, and we actually have Anna Hallis here, who led our audit section group on this and worked really closely with a number of suppliers. We can't have guaranteed to get to every single supplier, but most of the main suppliers, to ensure that by the time the standards came in, that they had their systems updated for you guys, and that they'd also started working on things like having your efficacy audit electronically, because it can be a bit cumbersome if you're used to doing your audit on your handheld devices, and then you've got to get a bit of paper out to do the efficacy audits. So I'm not going to go through this, you've all seen this, but it just gives you an idea that if you don't have a digital audit system, and we do know that more sites than we would like still are running their audits on paper, it's a simple way of translating your scores across to your star ratings and just helps that, but this is all within the documents. So this is another thing we've managed to deliver. I had hoped to be able to do the video, but unfortunately I couldn't quite download it in the right way, so technology has let me down, and I do apologise on that one. But the updated cleaning manual, so we know, those of you again who've been around for a long time, know that there's been an NHS cleaning manual since about the 80s. Lovely big thick document that got dusty on people's shelves and was refreshed, I think, probably originally around 2001 as a list of written methodologies with no photos and not much else, and it kind of remained that way for many, many years, which is not great if you're trying to train your staff how to do things that those of us that absolutely love to clean might want to sit and read a load of in-depth methodologies on how to clean a toilet or a sink or things like that. But actually, for most of our staff, they need something a bit more upbeat. So the new cleaning manual has got all those written methodologies, but it also has all of your posters, as well as bite-sized training videos to accompany those posters that allow and support training of your staff. It's currently available on our NHS Futures platform, but over the next few months we're trying to get that published publicly available, so it doesn't matter, you don't have to have an NHS email address in order to access it, although if you do need access to it, there are other ways to do it if you don't have an NHS email address. I believe it's on the AHCP website as well, isn't it? So yes, those who are members of that as well can access it that way. But the ambition is that it will be there more publicly available, and we will be looking to add to that on a yearly basis in order to refresh videos, bring online new posters, videos, etc., and make any changes, because as we know, things around infection prevention, etc., change regularly. So a little bit about our Exemplar Trust platform and what we've been doing here. So Royal Surrey and the team at MediRest are our first Exemplar Trust, or trust, to reach the status for both cleaning and catering. So the Exemplar Trust platform came about through food and catering and the food review, but it is widened out now to cleaning, to portering and other areas. Essentially, what they learned through doing this process was that they worked really closely with the board team, with the sponsors, looking at how they were going to run through the paperwork to ensure that they'd fully implemented the standards from the 1st of April, so a whole month earlier than they would, slightly more than a month earlier. And I know, I'm not going to steal their thunder because I know they're doing a special webinar on the 1st of December, isn't it, Anna? And there will be another slide that I'm going to ask Nolex to send out with mine as well that will give you joining instructions and a QR code for that. And they will go into a lot more in-depth information about how they did it and what they did and so on and so forth, and how they've achieved Exemplar Trust status. So this is a bit more about it. We know it has to be a whole organisational approach. So those of you out there that are thinking, do you know what, we do this really, really well. How do we become part of your Exemplar Trust programme? So this is a bit about it. There has to be a whole organisational approach. It comes from the top down and the down up again. You know, you need to be able to be challenged and provide assistance with pilots and innovation that we're running, because one of the great things about it is that, you know, we're looking at things in the background, innovations and stuff like that, and we need people to tell us, okay, this could work. We need things piloting. We need to be able to challenge us as well on why we're doing things. It's about being a flagship trust and being a representative of the central team as well. It's not just an excuse to put Exemplar Trust at the bottom of your signature. There is actually work behind it. It's ensuring that you've got great relationships between your clinical, catering, domestics, estates and other MDTs, whichever angle you're looking at. And for us, it's about having that set of trusts that have stepped forward and they want to be regularly involved in what's coming next, what's the new thing, how are we improving this and making things better. And that has now been around from a catering perspective for around 18 months, and we're sort of, as we say, we're now starting to bring on board trusts who are doing great things in the cleaning sector as well. So next steps, we are working very closely with ambulance and cleaning trusts. You heard Phil Shelley earlier, so my colleague Phil Shelley is leading that working group, building on the national standards. So we need to be really clear here. We're not having different standards for ambulance trusts. We are essentially taking the national standards of cleanliness and making them a bit more bespoke. For example, cleanliness charters and star ratings, we're not going to be sticking those up in ambulances because let's face it, if you're in the back of one of them, you probably don't really care how often, you know, the frequency of clean of things like that. So they do need some more bespoke things, and they've been working with, you know, a large number of ambulance trusts in order to make sure that the standards work there. There's some additional themes, obviously looking at their vehicles, the differences in their premises, how they can audit and governance. You know, ambulances are often, you know, in and out of hospitals, in their own places. There are some different things, and we've got some more specialist decontamination areas that are required there as well. So the work, I believe, the documents are just being finalised now with a view to a launch in April 2023. Obviously, for any ambulance trusts in the room, there will then be a compliance timescale, just like we've had for everybody else. That same working group is also working very hard on primary care. Different animal to acute mental health, hospitals, community, and everything like that. and we are working very carefully. We're building support tools for them because, you know, they're not necessarily used to using these types of standards, but equally it's about piloting some of that and working with a core team of GP providers and people from primary care teams to ensure that the bespoke tools we make for them work as well. And also an anticipated launch. Phil did pick up my error and I've forgotten, so that's on me. Obviously, they haven't been launched this year. We're looking at April 2023. So a bit about some of the lessons learnt going through this journey. It's been a long journey, as we know. 4 years from starting the project to actually getting them out there. And then, of course, they were out there during a period of a pandemic. And, you know, we're now, as we say, 6 months forward from that first compliance thing. So one of the main things that we're hearing is that power of partnership, multidisciplinary teams. You can't just, you know, do it in isolation. You've got to work with your infection prevention leads, with your hard FM teams, with your clinical teams, because you all have a part to play in cleaning. And the problem is if the domestics are doing a brilliant job, but actually nurses and hard FM are always scoring down here, it can be quite soul destroying. So there's something about bringing everyone on that journey, that now there's a star rating that actually you're going to bring our ward score down. We should be getting 5 stars, but because of this. So it's about thinking about things differently as well. It's an opportunity for organisations to look at how their services work and is it time to do something different. We always talk about anything overhand height becoming hard FM. Why? Because we've always done it that way. Because we couldn't trust a domestic member of staff to climb up a ladder because we only employ short cleaners. No, it's just because essentially that's the way we've always done it. So it's time to think differently. What if we upskilled our domestics? What if we gave them some ladder safety training? We showed them how to take off a radiator cover, gave them some tools, showed them how to take off a light fitting. Because we all know that electricians, builders, maintenance men are not the best people to do the clean. So they clean the light fitting and they leave lots of dirty hand marks around the ceiling that have got to be cleaned or don't get cleaned. If I'm lying in a bed and I see a dirty light fitting, I don't think, where on earth is the hard FM person? I go, where's the domestic manager? So let's control those things. Similarly for clinical stuff, you know, we don't go around trying to put in cannulas. So, but what we are expert is really good cleaning. So let's think differently about how we do things. Sometimes we know engagement is challenging. We've heard across the board where we get, you know, people will say, yeah, but we don't really talk to the hard FM boys. They won't talk to us. Or, you know, we don't really get on with the infection prevention people. But now's the time to make that happen. There's always a way to make it happen. And if it's not happening, come to me and Phil. We can support that happening. You know, we know COVID has made it difficult, but actually a lot of trusts have really taken this forward. I mean, when COVID first started, I got contact from so many people who sort of said, well, we're in a bit of a quiet period now, I guess, because a lot of hospitals had emptied out. And we've seen, you know, they knew what the pilot was and were asking, is it going to change significantly? Because when they commented on the standards, they wanted to know, well, can we get a forwards run at this? And we said, yeah, no, you know, essentially the ethos won't change. And obviously it's about trust's approach. Are they looking at how they're doing things? You know, are they actually reviewing what they're doing on a regular basis? How many of us in this room have been going on to a ward day in, day out, and there's one room there and it's down as low risk because it's a store cupboard, and suddenly, like 2 months later, you come on to do an audit and it's not a store cupboard anymore, it's now a clinical room. But no one's told us. Why would they tell us? Why would we want to clean it more frequently? So there's something there about having that, are we reviewing things on a regular basis across the board? You know, and at the end of the day, what are we migrating across from? It's not as scary as it sounds. We did have a lot of, and funny enough, in the beginning, a lot of people thought it was going to be terrifying. But once they actually saw the document and looked at it, most people were like, okay, so we're pretty much doing this. We're just changing the name of some things. And that is essentially me in a nutshell.